Thank you everyone for joining us and welcome. This is the Improving HPV and Pediatric Influenza Rates and Influenza and HPV Vaccination Rates in Louisiana webinar series. We are so happy that you could join us today. We hope that this webinar and this virtual community will be a place where you can learn from our speaker and your peers, ask questions, and we can all learn from each other. So today on our agenda, we'll do some quick housekeeping and then we'll move on to our presentation and we will have time for question and answer. This educational series is made possible through funding from the American Academy of Pediatrics and brought to you by the American Cancer Society, the Bureau of Family Health, School-Based Health Centers, Louisiana AAP, Louisiana Office of Public Health Immunization Program, the Louisiana Primary Care Association, the Louisiana Shots for Tots Coalition, LSU Health Science Center Dental Program, and the Southeast Louisiana AHEC. This webinar has been accredited for 1 AMA PRA Category 1 credits for physicians and 1.1 contact hours for nursing education credits. All Improving HPV and Pediatric Influenza Vaccination Rates in Louisiana Planning Committee members have indicated that they have nothing to disclose. This session is being recorded for educational purposes. A video recording of this presentation will be shared following today's presentation. By participating in this webinar, you give your acknowledgement and consent for the recording. As such, please ensure that patient privacy is protected and do not provide any PHI during today's question and answer period. Please make sure your microphone is muted during the session. You will have the ability to mute and unmute yourself to participate in our call. If you have any IT difficulty during today's call, please contact Ashley. You can chat her in the chat box or call text 225-505-7611 and she'll be able to assist you. If you do have video capabilities, we encourage you during question and answer to come on camera. It makes for a more interactive and engaging session when we can all see each other. Also, please enter, if you haven't done so already, please enter your name and where you're from in the chat box so we have, so we can capture your attendance and we can get to know each other a little bit better. All right, so today's presentation is giving a strong provider recommendation for the HPV vaccine. And today's presenter is Dr. Betty Loblaze. After earning her MD from LSU School of Medicine, Dr. Loblaze completed her internship and residency in medicine pediatrics at the same institution. She also served as chief resident in pediatrics for the 1996-97 academic year, and she joined the faculty of LSU Health Science Center in 1997 as assistant professor of clinical pediatrics and medicine. During her years at LSU, Dr. Loblaze has won numerous teaching awards. In 1998, she became an assistant program director for the LSU's Medicine Pediatric Residence Program, and she became the program director the following year. In addition to her many educational and clinical activities, she volunteers at several community service clinics. Dr. Loblaze is board certified in internal medicine and in pediatrics. She is also a member of the American Association of Pediatrics, the American College of Physicians, the American Society of Internal Medicine, the American College of Physician Executives, the Medicine Pediatrics Program Directors Association, and the Association of Program Directors for Internal Medicine. So with that, I'll now turn it over to you, Dr. Loblaze. Please feel free to start whenever you're ready.
Thank you so much for that introduction, that very kind introduction. Thank you all for being here today. I really appreciate it. I will get started. The basis of my talk today is giving a strong provider recommendation for the HPV vaccination. And I have received monies or will receive monies from a grant via the LAAP for this project. I'd like to share my objectives. So by the end of this presentation, hopefully you will receive some evidence to support the efficacy of the HPV vaccine. We're going to discuss barriers that hinder the vaccination rates, provide the current recommendations for administering the Gardasil vaccine, elucidate some effective strategies to improve our timely immunizations of the HPV vaccine, and provide useful and compelling information to help parents decide to vaccinate their children, and include resources to improve vaccination rates. So I think in order to have a better understanding of how to provide better information, have a better dialogue with parents, I think there's a need for a good understanding, a solid understanding about HPV as a disease. So when we talk about human papillomavirus, it is the #1 sexually transmitted disease, and there are over 150 types, but the strains that we're going to focus on are the more than 40 types that mucosal as well as genital epithelium. So we know, that HPV strains 16 and 18 are the most common oncogenic strains of HPV that are associated with cancers in the cervix, the anogenital areas, or pharyngeal cancers, as well as precursors of cancers and low-grade cervical disease. 6 and 11, although not oncogenic, do cause some diseases that can be psychologically devastating for some patients, including genital warts, laryngeal papillomas, as well as low-grade cervical disease. So a little bit about HPV infection. So most males and females will be infected at one point in their lives and not even know it, unfortunately. Approximately 79 million Americans are currently infected, and there are about 14 million new infections in the United States per year. Suki, yep, keep going. Okay.
I apologize.
Oh, no, this is good. So HPV infection is most common in teenagers as well as early adults. 50% of all new cases occur in the highest risk group, which we already know. This is the group 15 to 24 that are actually the highest rates for chlamydia and gonorrhea as well. You can advance. Up to 75% of HPV infections occur in this age group, 15 to 24 years of age. Keep going. And it's an equal opportunity virus, which means it affects males and females equally. And 8 out of 10 persons will have HPV before they actually turn 50 years of age. It's a staggering figure. So the mechanism of spread, this is important. It's skin to skin, primarily during intimate sexual contact from vaginal and or anal sex, but it can also occur from oral sex or infected sex toys. So penetration is not always needed. You can be infected with more than one type of HPV, which is why this vaccine is like so effective. And it can be spread by an asymptomatic person who doesn't even know they're infected and ultimately cause overt disease in an unsuspecting person. Keep going. So most people, again, will never know that they were infected. So if we look at the cancers that are associated with HPV and the ones that we are concerned about the most are on the left-hand side, we see that there are over 45,000 cases of HPV-associated cancers, and about 80% are actually caused by HPV. And if we take a look at cervical cancer rates per year from 2013 to 2017, this is a very stable number, about 11,000 cases HPV-associated cervical cancer occurs per year, and those are hard, fast numbers, reproducible over time. What's staggering is if you take a look at oropharyngeal cancers, we see that the number of HPV-associated oropharyngeal cancers, 11,800 in males alone, is actually exceeding the number of cervical cancer cases. And this is a new rising trend that's definitely of concern. So the total number of HPV-associated oropharyngeal cancers, 14,000, is actually exceeding the total number of cervical cancer cases, which used to be the most prevalent type of HPV-associated cancers. So there's about 36,000 HPV-associated cancers per year. And this is a staggering figure that tends to increase over time. So if you take a look at this graph, what you note is this light blue mountain-like peak. And this is the HPV-associated oropharyngeal cancer that I'm talking about. And we see that there is an early rise in the late 20s, a peak in the 70s, 60s and 70s, and a decline in the 80s. But compared to all the other male HPV-associated cancers, we're talking about anal, rectal, and penile cancers, oropharyngeal cancer is the highest, the fastest rising male-associated cancer at this time. Go ahead. So a study that was done by Maura Gillison, who's actually works with head and neck medical oncology at MD Anderson, she published a study in 2016 that really did take a look at the rates of oropharyngeal infections in 2,600 adults. And she is a leading investigator on HPV-related oropharyngeal cancers. And what she found was that just one vaccine, just a single vaccination, decreased the prevalence of oral HPV strains that were found in the vaccine by 88%. Keep going. So again, she has reiterated that oropharyngeal cancer is the fastest rising cancer among young white men in the US. And keep going. And she feels like this trend is definitely related to sexual transmission. Keep going. And the cause may be due to changes in sexual practices, sexual behaviors that have occurred from the 1950s through the 1970s. What no one is able to explain is why women are not infected as frequently as men. So we still do not have data to support why that is the case. Keep going. So if you look at the cases of HPV-related oropharyngeal cancer, we'll see that HPV 16, and I told you, 16 and 18 are the two most oncogenic strains, but 16 causes overwhelming the most number of oropharyngeal cancers that are HPV-related. And again, males are infected 3 times more than females. Caucasians more than African Americans, and we're seeing a younger group of young men and women infected. And so the median age is very young at 54. This is not a cancer related to alcohol and tobacco, as oropharyngeal cancers usually are. And it's affecting those in higher socioeconomic status and who are educated. So a completely different group than commonly thought of in the past. Keep going. So again, take home message, just one HPV vaccine dose was able to lower the oral HPV infections by 88%, but from those who were able to get this vaccine. Very, very, very powerful. Just one vaccine was able to lower it. Imagine if you got the full set, hopefully we would see 100% reduction, prevent it from happening ever. So when we talk about HPV vaccine, go ahead, keep going. We are targeting, we have a vaccine that's very, very effective, but we know that this is a vaccine that, like most vaccines, are made with virus-like particles. That is, it is not a live vaccine. It contains no DNA material. So it is neither infectious and it's not oncogenic. It cannot cause cancer. It does not cause infection. And actually, the immunogenicity associated with the vaccine is greater than natural immunization. So basically, if you got the infection, your antibody response would be lower than if you had gotten the vaccine. Keep going. So if we take a look at the content of our Gardasil 9, so Gardasil 4 was the original one in 2006. 8 years later, we have Gardasil 9. This is the only vaccine now available throughout the world. So 6 and 11, again, is targeted. 6 and 11 cause over 90% of genital warts. Again, genital warts will not kill you. However, it can be very psychologically disturbing for our young persons who actually get it. And then we see that 16 and 18 protected 66% of the HPV-associated cancers, primarily in the cervix. And then the additional coverage that the 5 extra strains produced an actual 15% extra coverage with cervical cancer strains that are associated with HPV. So we have a greater than 80% coverage of cervical cancer HPV-related strains, which is remarkable. So if you take a look at the current recommendations, again, vaccine can be given as early as 9, but there are immunogenicity studies that have been done, again, reproduced over time, that says the best age is 11 to 12 because of the more robust immune response. And the preference is to hopefully finish the series by 13. Now, we know that you can give the vaccine up to 26 years of age, and that is CDC recommendation. However, the FDA did approve that the vaccine can be given up to 45 years of age. That is not a CDC recommendation, it's an FDA approval up to 45. Next slide. So if you take a look at the dosing, which I think most people are familiar with, we know that again, it was a 3-dose vaccine schedule. And it still is if you give the vaccine on or after the 15th birthday. However, if we target the younger children like we are supposed to, then it's a 2-dose vaccine. So one now, 1 to 6 to 12 months later, but you can give the second dose as early as 5 months after the first. And then the 3-dose vaccine schedule again is one now, one to 2 months later, and the other one at the 6-month mark, but can be given as early as 5 months after the first shot. Let's keep going. So again, the recommendation is to vaccinate all males, all females, 9 through 26 years of age. Catch-up is not recommended. So guess what? If you didn't get it by the time you're 26, there's no recommendation to all of a sudden go get the vaccine. However, it is FDA approved. So if you choose to do it, have a discussion first with your provider who can make recommendations for or against you getting that vaccine. Go ahead. So there are certain populations that we are definitely going to recommend the 3-dose vaccination series. And that would be our immunocompromised conditions. And that only makes sense because they may have a more attenuated immune response. HIV patients, those with malignancies, autoimmune, etc. For those children, unfortunately, who have suffered abuse or assaulted, as soon as you can. So if it's 9, let's get it done as early as possible. So 9 years of age. Pregnancy, it's really contraindicated. There's no urgency to give it during pregnancy, so certainly wait. And if you're breastfeeding, you can get the vaccine. Next slide. So I think one of the pivotal points of discussion when we're talking about recommending vaccinations is to be able to safely say to our parents and patients that this is a very safe vaccine. Next slide. So there are so many studies that have been done over time over the past decade and a half to ensure that. But if you take a look at the left upper hand corner, what was that scene? That scene was when the World Health Organization had organized global vaccinations throughout the world to do what? To prevent smallpox. And guess what? It's now eradicated throughout the entire world since 1980. The last case was in Somalia in 1977. So guess what? Yes, it may be painful to get a vaccination, but the gain is just insurmountable. You can't even it's priceless. You can't put a price on it. Next slide. This is my daughter, and this is my mom. My mom was not able to get the vaccine because obviously it wasn't available, but she got all 3, as did all of my children. Next slide. And so Jacob, who's now 25, he did get the vaccine when it probably wasn't that acceptable at the time, but you know what? It's important whether you're male or female. There is some skepticism about the vaccine, but we're hoping that we can dispel that with some very evidence-based strategies. Next slide. So if we take a look at vaccine safety, there are so many mechanisms in place through the CDC and the FDA, and I'm not going to read all of these, but not only to monitor adverse events, but also continued ongoing surveillance about efficacy, as well as side effects, as well as long-term outcome studies. Next slide. So more than 120 million doses have been distributed in the United States alone since the Gardasil vaccine was first introduced in 2006. And this is not even including what's been going worldwide. So we know that there's been extensive testing, and they'll even tell you the number of patients that actually had gone through studies before the vaccine was actually launched. Next slide. So if you look at all the safety data, you will realize that the reactions from the HPV vaccine do not differ from any vaccine that we give, whether it's Tdap, Menactra, hepatitis B, et cetera. So the most common vaccination events are going to be the local site reactions, which is just pain and swelling and redness. And you can have some fever and headaches, et cetera, maybe some body aches, similar to what we've gotten with the COVID vaccines. Keep going. But if you take a look, most of the people who have issues are, if you have an allergic reaction, then you should probably not continue with the vaccine series. That makes sense. And if there's any hypersensitivity to yeast, you definitely should not get this. Go ahead. And then what is common or not uncommon is that sometimes we do see some adolescents have some syncopal spells that they easily recover from. And so we do recommend that our patients either sit down or lie down for at least 15 minutes after administration to ensure that they have recovered from these events. So in the US, if we look at anaphylaxis rate, only 3 cases per 1 million doses administered. Very, very, very safe. Again, if you have severe allergies to any component of vaccine, you should not continue with that series. Next slide. So again, let's reiterate, the vaccine is safe and just as safe as Menactra and Tdap, which would be administered at the same time. Go ahead. We know that it's effective. We have early as well as mid outcome studies throughout the world that are proving that we're seeing decreased rates of genital warts, as well as decreasing rates of precancerous lesions, and that we know it lasts. So there is no evidence of waning immunity. We know that it can last up to a decade, but ongoing studies are showing that probably even longer. Next slide. So what's important is, given the body of information that we know, is how do we convince parents who may be struggling with the idea of vaccinating their children with the Gardasil vaccine? How do we frame this conversation with evidence-based materials? Next slide. So just looking at our rates in Louisiana compared to the rest of the country, for once we are actually doing better than most states. Yay! And when we take a look at the vaccination rates in Louisiana, our rates are better than what's in the United States at 53%. So 53% of our children are fully vaccinated with the Gardasil vaccine. Next slide. Oops. I think so in this slide, again, we're trying to show you that Louisiana actually has done better than the United States, with 69% of our kids getting at least one vaccine and 53% are fully vaccinated. Next slide. So if we look at our HPV vaccination rates, yes, we do see a trend that there's an increase from 2013 to 2018 in the number of vaccinations that are given. However, what is really disconcerting is that we're seeing as we see a rise in the number of HPV vaccines given, we're seeing there's still a discrepancy in the vaccination coverage between rural, which is the red line, and the gray line, which is the mostly urban on the top line. And there's about a 12% discrepancy in those rates. Next slide. So again, if you take a look at the light blue, which is urban, the middle blue is suburb, and then to the right is our rural. You can see that with the exception of Tdap, the discrepancy in vaccination coverage between urban, suburban, and rural is staggering, especially noted with the second booster dose of Menactra. But it's noted in both HPV vaccine, whether one dose is given or whether 2 or 3 doses are given. And this is a point of real concern, that our rural areas are not being vaccinated at the same rate as urban and suburb populations. Next slide. So why do we feel, or what factors do we feel are associated with this discrepancy? Well, one of the biggest factor is that fewer parents in the rural areas might not be getting that recommendation from their provider. And we do know that the clinician's recommendation is the #1 reason parents decide to vaccinate their children. So 70% of rural parents getting that recommendations versus 77% of urban parents. Next slide. So when we look at the potential etiologies of the rural versus rates of vaccinations, there are some hypotheses as to why. So there's a possibility that the rural residents are less likely to have knowledge of HPV and be aware that it even exists and that its role is to help prevent cancer. There's a shortage of providers potentially in the rural areas as well. And then some of the providers may not be as savvy and knowledgeable about the up-to-date vaccinations that adolescents must receive. Next slide. So a study done in rural Alabama to really elucidate again the difference in the rates of rural and urban HPV vaccinations. They felt that even the providers needed better education about this vaccine. We needed better communication. So providers needed to be educated to be able to communicate the importance of this vaccine when they're speaking to the parents. And again, finally, the strong provider recommendation is the most influential reason why parents decide to vaccinate their children. Next slide. So if we look at the Vaccines for Children program, this is a wonderful program that will provide vaccines for free to all children 18 years and less who are uninsured or Medicaid eligible, or who are American Indian or Alaskan Natives. Next slide. So when we look at barriers, this is a huge barrier. Okay, so one of the biggest barriers is the clinicians themselves. So unfortunately, in this slide, what we see on the left column, the dark blue, is overwhelming, like, positive value that parents are placing on all vaccinations, including the adolescent vaccines, Menactra, Tdap, and HPV. And then the light blue, the right part of the graph, is what the clinicians perceive that the parents place as far as value on the vaccines. And you can see that for the flu, for HPV, for just adolescent vaccines, there's a disparity between what the clinicians feel, or how much value the clinicians feel the parents place on these vaccines. Next slide. So unfortunately, this perceived and real concerns of the parents does influence how the providers are administering this vaccine and how they're recommending it. So if the clinician does not feel that the parents think it's important, then they may not be recommending it the way they should. Next slide. And we see that in this survey of parents, 10% of parents who were not getting their children the HPV vaccine stated it's because my provider did not make a recommendation. That's so powerful. So provider recommendation, again, is the best predictor of vaccinations for any vaccine. Next slide. If we look at just vaccine coverage, okay, so if amongst the adolescents who received a recommendation from their provider, 75% agree to the vaccine. But if we look at the arm of those who did not receive a recommendation, less than 50% of those patients agreed to the vaccine. So again, just that provider recommendation overwhelmingly increases the rate of HPV vaccinations. Next slide. So again, giving an effective recommendation is at 11 and 12 years of age was associated with, again, with parents reporting that they had received a effective recommendation from their provider. And that's because they trust us as the providers to make effective and healthy recommendations that are going to keep their children safe. So when we looked at moms and focus groups, again, they reiterated that exact same premise, that they trusted their child's clinician and they would get the vaccine for their child as long as they received a recommendation from the clinician. Next slide. So if we look at 5 ways to boost vaccination rates, again, bundling the vaccine. So the Menactra, the Tdap, the Gardasil should be bundled together and given the same way in the same day. We have to ensure a consistent message. All mid-level providers, all providers should be sending the same message that yes, we believe that HPV vaccine is effective in helping to prevent cancers in the future. Use every opportunity to vaccinate. I can't state this enough, whether they're coming in for a skin rash, a sports physical, you know, an acute illness, as long as they're not, you know, too sick. Take advantage, take a look at the vaccines that they are not up to date and make those recommendations at the time. I love providing personal examples because I have 3 children, ages 17 through 25, and all of them have been vaccinated. And I can safely say that none of them had any adverse effects. And I'm hoping they're going to reap the benefits in the future with cancer prevention as a result. And you always want to effectively answer questions, really develop like answers that are going to answer the questions that the parents may have to quell their fears. Next slide. So what is an example of an effective recommendation for the HPV vaccine? So again, important, you have to recommend to give it to them the same way, the same day. Next slide. So what do we mean by the same way? Well, if I'm going to give at 11 to 12 years of age, our school age kids, 6th graders, if they already need the Tdap and Menactra, we're going to give you all 3 vaccines today in the same exact way. I'm not going to place a different emphasis on any one of those vaccines because they're all equally important. Next slide. So an example of what you could say is your preteen needs 3 vaccines today to protect against meningitis, HPV cancers, and pertussis. Next slide. So we know announcements like this are more effective than conversations. An announcement already assumes that the parent is willing to vaccinate their child. Again, an example. Now that Sophia's 11, she's due for 3 vaccines today. These will help protect her from infections that cause meningitis, HPV cancers, and pertussis. We'll give you shots at the end of the day, at the end of the visit. Next slide. So again, not all parents are going to be, willing to get all 3 vaccines, but most of them will. And I've noticed in our clinic, we have an 80% HPV vaccination rate. Most of them really are receptive to this bundled recommendation. But some parents may still be interested in vaccinating, but they have questions. So do not, perceive that asking questions is related to refusing or delaying the vaccines. They just have questions that they trust you as a provider to provide some reassurance and some answers to questions that they really have. So we definitely want to make sure that we are addressing the primary concerns that they're having. And if we do that, then we can actually give them an effective recommendation and then save time for both parties to ensure that they understand the value of this vaccine. Next slide. So we're seeing the age of vaccine hesitancy with COVID primarily, but the hope is to reframe the vaccine hesitancy into vaccine confidence. So rather than focus on hesitance, let's focus on why is this vaccine, why am I so confident about this vaccine? Well, first of all, I'm confident because the recommended immunizations that are put forth by the CDC were recommended to, again, prevent diseases that ultimately can cause death. The second one is that you're the provider who's making the recommendations, and I'm hoping that your patients trust you. Also, we hopefully are placing trust in the policies that are being made to create new vaccines with the end goal of, again, preventing disease, preventing death. So vaccine confidence is really critical to helping to increase our vaccination rates. Trust is the key foundation to establishing this vaccine confidence. So having the resources available at your fingertips, being able to communicate this message and answering our parents' questions are key to vaccine confidence. Next slide. So again, vaccine confidence is critical to maintaining the vaccination coverage rates. We need to do everything that we can to ensure that we are doing our best as providers to provide that trusting relationship with our patients and with the parents. So again, this is like one of the most pivotal roles that we can be playing as providers. Next slide. We can keep going. So if a parent does have questions after you make a recommendation, please listen to these questions and respond appropriately. Again, a lot of times they just want your answers. They don't want what they've read. They don't want to hear from their friends. They want to hear it from someone that they trust. So but the fact that you're willing to listen to them really helps with the trust building that you have, so that when you make that recommendation, the hope is that they will definitely be very, very receptive. So again, if you encounter questions that they may have, instead of being defensive, you definitely want to try to answer and give them that information and share what you do know, and then to acknowledge that, yes, I hear your concerns. I will go and look this up.
let me research the latest information about the concerns you may have. Next slide. So if a parent does decline today, do not take that as the final answer, because guess what? We want to have ongoing dialogue. So what we recommend is that, yes, we should end that conversation with at least one action we both agree on. So perhaps, hey, the next time, when Joey is ready for his flu shot, let's bring him in and let's talk about the HPV vaccine at that time. Or you can call my office at any time, and let's have a discussion. And you can bring him anytime for a nurse visit. More than happy to have him come at any time to get the vaccine. Next slide. So with the subsequent slides, and I'm not going to go through all of them because these are questions and answers that you can read on your own, that basically is a dialogue between you and the patient or the parent that helps you hopefully give a little script of answers to questions that parents frequently have regarding the vaccine. One of the most important reasons why we want to give this vaccine early and not wait until 13, 14, even 16 is because it's going to be more effective when we give the vaccine before a child becomes sexually active. So before they become infected with various strains of HPV, we want to have them covered with the HPV strains to help prevent them from actually being infected in the first place. So I'm going to conclude. As you look through the many slides that I have, there's also some very important informational slides that tell you that are available through the CDC, fact sheets that are available for both your office workers as well as for parents, to help answer some questions that they may have that you can easily give to them at the end of the visit. There are wonderful videos as well, demonstrating examples of how providers have communicated with their parents regarding the HPV vaccines as well. So this concludes my presentation, and I'm more than happy to entertain any questions that you have.
Thank you so much, Dr. Lilies. That was such a wonderful presentation. And I'll just say a lot of times in ACS, we talk about closing the gap between boys and girls, but it was a good reminder of rural versus urban. And I think that's something so important to keep in mind. And I also liked how you talked about vaccine confidence. I thought that was great.
Yeah.
And so we're going to open it up for questions. Feel free to come off of mute. If you'd rather put it in the chat box, go ahead. So I'll kind of kick us off just leading off of what I just said. So obviously, a provider recommendation is incredibly important. Is there any issue with access to pediatricians or just a physician in general that could lead to some of those gaps of rural versus urban, particularly in Louisiana?
So, Caitlin, I'm not really following what your question is, though. Say that one more time.
So with vaccine rates being lower in rural areas,
yes,
is it mainly due to some of those issues of provider recommendations, or many of the things you discussed? Are there any issues around access to a physician or a doctor to administer the vaccine?
So I think once again, if you polled a lot of physicians, honestly, right now, I think there's not going to be so many physicians who feel comfortable talking about HPV vaccinations. And that's why I tend to load my slides up with background information, which you assume many people know, but I guarantee you if I quizzed doctors right now, they don't know this. And that's why it's so important to have a good understanding. So I don't think that the vaccines are not available. I think there may be some hesitancy from physicians to administer vaccines that they really probably are not well versed discussing. That's my feeling at this point. And then I do think there's not enough physicians in the area, in rural areas. And so they may not realize that, yes, just because it's not required by school. So if you think about it, Menactra Tdap are usually required by schools. However, HPV vaccine is not on the list. It's not going to make the list. And the reason why is because it's not a public health threat immediately. It's not an infectious disease that is going to cause half the children to miss school. And so as a result, I think it becomes less important sometimes in the mind of physicians because they're not seeing the big picture. This is about like not today. And as a med peds physician, I have seen beginning, middle, and end. So I worked in student health. I see the genital warts, and those patients are not happy with that. If I said, could I take this away? Could I have prevented this? And they would do anything at this point to say, I wish I had that, right? So I think we need to be less myopic, right? And look at the big picture. Yes, I'm giving this vaccine not for today. I'm giving it for next year, the year after that, the year after that. I'm giving this to you so that when you become an adult, I don't have to worry that you're going to have cervical cancer and need a hysterectomy, never had children. I'm not going to have to worry that you're going to not have your voice box because they're going to have to do a laryngectomy because you have oropharyngeal cancer. So that's what I'm trying to prevent in the future. And I think if people just said it that way, I think maybe it made more sense.
Yeah, I think that's an excellent point. Thank you for that. Do we have any other questions? Well, we did get some thank yous in the chat box and indication that you gave an excellent presentation. So again, thank you so much. That was really wonderful.
Thank you.
I want to remind our participants to take our evaluation. It helps us for future planning and to record your participation. Ashley, I'm going to turn it over to you for some follow-up information.
Perfect. So thank you again, Dr. Lowe. That was phenomenal. And actually, I've seen a lot of these presentations, and that included a lot of things that I haven't seen before and some really excellent suggestions on language to use, which I think providers are always looking for. What can I say that so I can feel comfortable having those conversations? So thank you again so very much. And thank you to everybody who joined us today. This is our last webinar of the series. The panel discussion that was scheduled for July 1st has been canceled, so just take note of that. This will be our last series. However, we are continuing the conversation around HPV and how, what role we all play in increasing our vaccination rates and decreasing the prevalence of HPV. So you'll see on your screen information about our 2021 virtual HPV summit. So I will encourage everybody to take their phone right now and scan the QR code that's on your screen. That'll take you straight to the registration page. Even if you are only able to attend part of it, you'll get all of the materials from that. And we're hoping to provide a box of information to everybody who registers as well. So it's scheduled for July 23rd. It'll be 9 a.m. to 1 p.m. We've got a really great lineup. I will share that Dr. Melinda Wharton with the CDC is going to kick us off that day, which is super exciting. We've got folks, other national folks that are going to share some really interesting and different information and perspectives with us. So hopefully everybody here will be able to make it. That information, along with the slide deck from today, the link to the evaluation and the video of recording from today will be sent in an email in the next day or two. So look for that in your inbox. And then I will pop up on the screen the link to the evaluation. So please take a couple of minutes. That link is also in the chat box. You can click on it there. We appreciate all of your feedback. We'll share that with Dr. Lowe as well, so she can have that. So lots of kudos. It also is how you will obtain your CME and nurse CEU credits. So I will leave that screen up there a little longer just so folks can have that. If you have any other questions, certainly feel free to come off of mute or put a question in the chat. We'll stay on for a few more minutes, and If not, have a great, wonderful day. And thank you again for being part of our series.